Hello, I'll talk about thyroid ultrasound today. In this presentation, I'll talk about thyroid ultrasound and its use in diffuse diseases and nodules of the thyroid, and I'll compare the ACR thyroids and ATA classifications. So we'll talk about both diffuse thyroid diseases and ultrasound in thyroid nodules, and talk about a little bit about reporting. Thyroid imaging is basically relying on ultrasound, and PET-CT or other nuclear studies are seldom used nowadays, and CT and MRI, computed tomography and magnetic resonance imaging also has limited or exceptional role in thyroid imaging. So how can we do the differential diagnosis in several diffuse thyroid diseases? Not certainly, not perfectly, but we can do it. We can describe as multinodular goiter, Hashimoto thyroiditis, Graves thyroiditis, decurrent thyroiditis, postpartum thyroiditis with the clinical knowledge, of course, and very rarely we can talk about renal thyroiditis, and there are some drug-induced thyroiditis and amyloidosis. Maybe the most important part of the ultrasound in thyroid is the differential diagnosis of thyroid nodules as benign or malignant. What are the thyroid dimensions? In adults, the average thyroid dimensions are 50 to 15 millimeters. The upper limit is 60 millimeters in the longitudinal axis and 20 millimeters on both the AP diameter and transverse diameter. So totally the volume is 7 to 10 milliliters, and the upper limit is around 20 milliliters. It is different in males and females. In the newborn, the thyroid gland is 18 to 20 millimeters long with an AP diameter of 8-9 millimeters. Let's talk about diffuse diseases of the thyroid. Multinodular goiter is probably the most common diffuse thyroid disease. By ultrasound, we can see confluent nodules mostly with no normal parenchyma between the nodules. Sometimes there is a normal parenchyma between the nodules. So if by some reason the thyroid gland is taken out, we can see the nodules, as you see here in the pathology specimen. Hashimoto thyroiditis is quite common also, especially in the young women. This is a 47-year-old female, and the patient has Hashimoto for 10 years. The thyroid gland is hypoechoic, heterogeneous, and lobulated, as you see here. It's a typical Hashimoto pattern. This is another patient. On the left, you see the image in 2018, and after 3 years, on the right side, there is mild enlargement of the gland, and it is more heterogeneous now. Very frequently, we see that within years, the Hashimoto disease makes the thyroid gland atrophic. Here is an example. As you see here, the gland is atrophic. And this is another patient. It's a man of 53 years old, and bilateral multiple typical white knight nodules are seen in the base of Hashimoto gland. So these are spheric, tiny nodules, homogeneous echogenic nodules. And another property, another feature of Hashimoto disease is the Delphian lymph nodes that are seen, as you see here. The Delphian lymph nodes are usually anterior to isthmus, in the midline, or inferior, caudal to the thyroid gland. Graves thyroiditis or Basedow-Graves disease is another thyroiditis which is less common than Hashimoto. This is a 60-year-old man with Graves disease. On grayscale we can see the heterogeneity, and by color Doppler and power Doppler you see how hypervascular the gland is. We call this the inferno pattern. And another female patient, the typical inferno pattern of the Graves disease is seen also here. This is another patient, the grayscale and the color Doppler findings of Graves. This is 62-year-old female, and you see that the gland is still very big and still hypervascular. The patient had Graves disease for 50 years, but still the velocities are high and there is hypervascularity still after so many years. So, can we differentiate Hashimoto or Graves from other thyroiditis? Basically, it's not easy, but we have some clues. What are these clues? Both make the thyroid gland hypoechoic, heterogeneous, and the gland becomes lobulated in contours. It's said that Hashimoto makes the gland hypoechoic more in the peripheric part, and the Graves makes it in the central part. But this is not certain, of course. Usually, Graves is hypervascular, Hashimoto is hypovascular, but we know that in the initial phase or in some phase, it can be hypervascular also in Hashimoto. And this is regarded as very specific. In Graves disease, the arterial velocity usually is about 40 centimeters per second. By time in Hashimoto disease, we can see atrophy, pseudonodules, and white knight nodules. Pseudonodules are hypoechoic, white knight nodules are hyperechoic. Graves usually doesn't lose much volume. They can still be hypertrophic after many years and may develop small cystic foci by time. Delphian lymph nodes are quite specific for Hashimoto, but they can be seen in other thyroiditis also. It's not 100%. What about decurrent thyroiditis? Actually, if we know the sonographic features, we can differentiate decurrent thyroiditis, and the pain, the local pain, just pressing the probe may give the patient pain if you are on the right point. So this is a 37-year-old female. You see the right lobe. There are many hypoechoic areas, but they are ill-defined. This is another patient with decurrent thyroiditis, and you see the hypoechoic nodules with ill-defined borders. The important point is that these nodules do not have vascularity. They are hypovascular. Postpartum thyroiditis, an example of this postpartum thyroiditis in this 37-year-old female. You see the heterogeneous gland. Actually, we cannot differentiate it from Hashimoto thyroiditis. In the last 20, 30 years, this polycystic thyroid is introduced as a new entity into the literature. And we have seen few cases which are really polycystic, but they change by time. This is an image of a 14-year-old girl who has polycystic thyroids. Actually, it was first described in 2010 by Kubota in Japan, and it is said that it's more frequent in the Japanese or Korean patients. The ratio of polycystic thyroid is almost 8% among hypothyroid patients. It's the cause of hypothyroidism in patients with high iodine intake. It's most often confused with Hashimoto. It is 3 times more frequent in women, and the average age is 66. And in the last 10, 15 years, we often see, perhaps this is because we see more details, we don't know exactly, that we see too many colloid foci in young people, especially when we are working together with students. Almost half the young students have this type of thyroid, which is similar. Maybe it's a variant of polycystic thyroid, we are not sure yet. There are peripheric colloid foci bilaterally. It can be a form of early malnourishment. This is a 19-year-old female. You see the peripheric hypoechoic colloid, tiny colloids. So another diffuse disease is amyloidosis. This is very rare, and you can appreciate the high attenuation in these cases. Amyloid goiter can also be imaged by CT, as you see here, and it's usually due to end-stage renal failure. What about the thyroid nodules? If we come to the thyroid nodules, we know that they are especially frequent in the elderly women. The incidence is said to be between 40–80% for adults. But we know that with high capacity machines, high resolution ultrasound instruments, it's not easy to find a gland without a tiny nodule, without a colloid foci focus. Especially with the new machines, we can say that the frequency, the incidence is quite high. But we know that the malignancy rate of these nodules is quite low and usually below 25%. We must do something. More than 90% of these thyroid nodules are not malignant, so we must stop following up, or we must not biopsy all these nodules. So we have stratification criteria, and after 2005 there have been many systems, but the most used 2 or 3 of these are ACR thyroids and Eurothyroids classifications, and on the other hand American Thyroid Association stratification system is also quite popular. It has been established in 2015. So, to summarize, we can say that we can be confident with two types of nodules. The first one is the typically benign. If the nodule is typically sponge-like and completely cystic, then we can surely say that this is thyroid 1 or 2 and it's benign. There are some nodules that we can easily, in a period of seconds, we can say that this nodule is typically malignant. These are mostly hypoechoic, most have microcalcifications or punctate echoes inside. They have irregular borders and they are taller than white. Then we say this is thyroid 5 certainly, or probably malignant. So on each side we have benign and malignant nodules. We can easily differentiate them, but there are many nodules. Maybe the most frequent nodules are thyroid 3 and thyroid 4, or we cannot be sure if it's a typical spongious nodule or not. So if we are sure that a nodule is spongious, if it is typical, then it's thyroid 1. But in practice, we meet many atypical spongious nodules, and then we have the problem if this is thyroid 1, if this is thyroid 3 or thyroid 5. This is a typical sponge nodule, but since it is big and it was growing in size, because of the size concern, the surgeon convinced the patient for operation and it was operated. This was also a big spongious nodule according to American Thyroid Association criteria. Still, if they are big, they should be biopsied. But in the ACR criteria, spongious nodules should not be biopsied. We can see with color Doppler that these nodules may be hypervascular, these sponge-like nodules. This was also taken out because of the anxiety for malignancy, but it was benign. So, look at this nodule, for example. If you cannot see the reverberation artifact or commutative artifact behind the punctate echoes, then you have to say that this is thyroid 4 because it is solid hypoechoic and we see punctate echoes. We are not sure if they are colloid or not, so this should be followed up or biopsy. This is another similar case. There are punctate echoes. We are not sure if this is microcalcification, but we have to give 3 points. So the contours are irregular. So this nodule in the 43 years old female seems to be then suspicious and should be biopsied. This is another atypical spongious nodule. You can say it is thyroid 3, it is isoechoic. You can say, oh, it seems spongious. Or you can be more suspicious and say that this is solid, this seems solid, and it has microcalcifications, so it should be regarded as thyroid 5. Another group is the cystic or semi-solid, semi-cystic nodules. So, if we see only colloid or coagulum, then we say this is thyroid 1 mostly. Sometimes, rarely we use thyroid 2. If there is no real solid component, Doppler is very helpful in this aspect, then we can be confident. But if there is a solid, irregular component, with vascularity, then we should not say it is thyroid 1, we should say it is thyroid 3 or thyroid 5, depending on the solid part, as the ACR recommends us. This is a 45-year-old female. This was a suddenly enlarging nodule. It is, we can appreciate that it is a hemorrhagic cyst. So there is colloidal hemorrhage inside the nodule, and that's why it has enlarged. There is no real solid component, so you can say this is thyroid 1. This is another young patient with 4 centimeter big colloidal cyst or nodule, we can say, but it is completely cystic, so we can say confidently that this is thyroid 1. But what about this? There is a solid component, it's not regular, it has vascularity, so we have to assign points for predominant solid component. There are septa, we don't know if these are benign or malignant, so we have to do something for these nodules, follow up or aspirate from the solid part. But using Doppler, for example, in this nodule, we can appreciate that the echoes inside the nodule are in reality are coagulum or hemorrhage. So we can say that this is thyroid 1 or thyroid 2, looking at the vascularity and looking at the sonographic features. If it has a level, then we can say that it is hemorrhage. But it's not always so easy. Look at this patient, it's 44 years old female. In 2019, the cyst is completely simple without any septa or solid component. But later, the nodule is enlarging and the solid component is changing and it has vascularity. So we should say that this is thyroid 5 based on the solid component. We are still following this up. Yes, there is a large solid component here in this patient, 55 years old male, and there is vascularity looking at the Doppler. Although the elastography shows us that this is soft, we can't rely on elastography. The contours are irregular, there are punctate echo, so this is thyroid 5. We have to go on and biopsy and follow up. But this patient was operated and it was benign. Similar patient. This time the patient is younger, 24 years old female. But although it seems similar to the previous case, you see vascularity, irregular borders, and it is partially cystic, but the result is cystic papillary cancer. It is very similar to the previous case. This is another similar case, it's quite old case from 2006. We can say that there is a cystic component and the solid component has vascularity, and this resulted with a pathology of Hertel adenoma. What about the solid nodules that are thyroids 3, 4, 5? This is a Hertel adenoma oncocytic variant in a 42 years old female. Only 20% of these Hertel cell neoplasms are malignant, and they are usually seen in the elderly. But you see that this is a huge lesion and excision is necessary for diagnosis in these cases as in follicular neoplasms. So this is another case with a big solid nodule. This is thyroid free, but it was taken out and incidental micropapillar components were found within this adenomatous nodules. This is another case. The nodule has regular borders, high vascularity, so it is thyroid 4, depending on the criteria, and it is soft in elastography and turned out to be a follicular adenoma in the final pathology. Eggshell calcifications are not very dangerous, but should not be ignored. This nodule had multiple biopsies and no malignancy was found, and it is stable after 3 years. This is a quite typical thyroid 5, multiple microcalcifications, irregular borders, and it is a papillary cancer in a young patient again. This is also quite typical. It is taller than wider and has all other properties, irregular borders, very hypoechoic, punctate echo, and it's a thyroid 5 malignancy. The microcalcifications or macrocalcifications can be seen, as in this case these are macrocalcifications in a thyroid 5 malignant nodule. Another nodule, thyroid 5 nodule, hypoechoic, orientation is taller than wide. This is another patient with a quite typical thyroid 5 papillary cancer. And sometimes we can see the lymph nodes, the enlarged lymph nodes, or the patient comes to the doctor with a swelling in the neck. So the nodule may be small, but the lymph nodes may be larger. You see a case like this, and this patient also had come for carotid Doppler and multiple lymph nodes, pathologic lymph nodes were seen with calcific fossa, and then we turned back to the thyroid and we have seen this 6 millimeter thyroid 5, as you see on the right side. The tumor, the primary tumor is very small, but the lymph nodes are very enlarged. This is another patient with conglomerated multiple big lymph nodes. This is thyroid 3 lesion. It was biopsied because it is bigger than 0.5 centimeter. It has regular margins, as you see. It is papillary cancer, the follicular one. Sometimes, rarely, we can see, especially in children and in young patients, diffuse sclerosing variants of papillary cancer. And we should be careful about these because they may not make a mess, like in this case, 26-year-old male, or in this case, you see that the right thyroid gland is very big, left is normal, and there is diffuse infiltration, diffuse macrocalcifications in the right side, and it was biopsied on the right side, and there are lymph nodes also, so the final diagnosis is diffuse sclerosing variant, but we should be very careful because there may not be any focal lesion. This is a 39-year-old male. The pathology is angio-invasive follicular cancer. This is an incidental malignancy, very small, 7 millimeter, 9 millimeter, it's a young student, incidental case, and